It's good to see people, and great to be back here at the Bethel Synagogue. We've been here, this is our 10th year in bringing people together to talk about disability and mental health issues. I'd like to think we were doing it before it was cool, but it's getting cooler, and that's a good thing. And during today, we're going to meet some of my colleagues as well who are doing similar events throughout the state. This is good. This is exactly what we hoped for. What's up? It's exactly what we hoped for when we started this thing right here 10 years ago. And I always have to give a shout out to Bethel because when I tried to get this going, we were rejected from one facility after another to the point where we were about to forget it because, no offense to our other churches and synagogues, they didn't like it. And then we came to Bethel, and Bethel loved it. And Bethel got it. And Bethel has, since that time, been a fantastic host, letting us use everything up here, right, on what I would consider an altar. I hope, where's my, is this still an altar? What do you call it in Hebrew? Bema. Thank you. Okay. There, thank you, brother. Thank you. So they let us use everything, and we're always very thankful for that. So I have to give them a special thank you for 10 years of support, which has been tremendous. For those of you who don't know, I'm Representative Dan Miller. Since last we spoke, I'm the majority whip. That's interesting. That's interesting. So, but like with every title, the key thing is what do you do with it, right? Because my son doesn't care about the title. He's not impressed. But when I talk to him about how we can help people and what we can do, that registers to my 16-year-old. And so that's the key. That's what we're measured by, right? It's never the title. It's what you do with it. And so hopefully what we're going to talk about, too, we're going to be focusing a lot today on legislation, on talking with legislators. We're going to have Democrats, Republicans. We're going to have senators. We're going to have representatives. And we're probably going to have a couple special guests along the path as well. So we look forward to that. But the key thing, of course, is to have that dialogue, to grow understanding, and to move forward. I bumped into somebody recently with a conversation, and in reality, she was sharing a story about how stigma is still impacting so much of what's impacting her family. I'm glad that we're talking more about mental health and disability. I do think sometimes I hear it spoken about in a way to score political points more than actually advancing issues, and that's not right. That type of use of disability and mental health does no one a service. And then again, I get people come up to me and they say, well, we just got to get the system back in place how it was before the pandemic, back to February 2020. And I'm always like, I don't care about that. That's not my goal. Right? February 2020 was not the promised land for disability and mental health services, right? I have no interest in getting back to February 2020. We have to be building off of that. And every day that we're delaying is a day of need that's not being met. So we got a lot to do, and we're going to talk about that. And it's good, and I'm glad. And we're going to try, sometimes somebody said, well, look, you focus on the negative, right? So I'm going to try and not do that as well. We're going to talk about a lot of the positive things that make up this story. So this is a good thing. And we're going to start today. We're very thankful to reach out to the Shapiro administration. And if you haven't caught it, Governor Shapiro has presented a budget that offers some kind of pretty interesting things, especially for mental health. And that's going to be, I love it because I think it's going to help frame larger discussions as the budget in Harrisburg gets done. And that's what we're going to be working on from now basically until the end of June, is to deliver that state budget. But in order to do that, some people come up and they say, oh, well, Rep. Miller is like some expert in disability or mental health. You all know that I'm not, right? Thankfully, though, we bring people who are. And so I'm very excited. We're going to start off with a great sort of, I'll say, keynote on mental health. But a speaker here, how we're going to set it up is that we're going to be hearing from our speaker. We're going to be going into question and answers afterwards. You raise your hand. We're going to pass out a card to you. We'll collect them. We will get to as many questions as possible during this time. So we're going to be doing that. I understand there's a cool slideshow, right? Is it cool? He's smiling. All right, it could be cool. We think it's cool. So we're going to be doing that. So that's going to be our 9 to 10 o'clock frame. From 10 to 12, these seats will be taken up with some of my colleagues as we will go more into a legislative hearing. I'll tell you more about that as it comes. 11 to 1 o'clock is our resource fair. 1 o'clock starts our disability programming, and we're going to finish up strong from 2 to 4 with another panel. That's what we have in place. I hope I'm speaking quickly to throw off our interpreters. All right, she seems good. So that's what we have, and so thank you for being here, okay? Let's start it off with our programming. Our first speaker is Dr. Dale Adair, who serves as Pennsylvania Department of Human Services Chief Psychiatric Officer and the Medical Director of the Office of Mental Health and Substance Use Services. In this role, he provides clinical expertise and consultation to the Deputy Secretary of OMSAS and the Secretary of DHS. He provides input and guidance into the policies which will affect the provision of mental health and substance use treatment throughout the state. He is a psychiatrist by training with over 30 years of experience and a life fellow of the American Psychiatric Association. He recently served as a co-chair for the Behavioral Health Commission for Adult Mental Health, which we're going to be talking more about as well on our legislative panel. I'm very thankful to have Dr. Adair here. Please help me welcome and thank you. Thank you. Thank you. You using my mic? The other mic.
Yeah.
Good.
We on? All right. Good morning. Representative Miller, thank you and your team for inviting me to participate in this day. I'm excited to be out and amongst people because it's been a minute since I've done a live presentation. Those who may have seen it in my presentations in the past, I usually will do, I like making things fun. So I usually have animated cartoons in my slides. It's been 3 years since I've done that, so this one doesn't have it. I apologize. If he invites me back, I'll give you that the next time. I want to give you kind of an overview of what I'm going to talk about, and I'm going to end up leaving lots of time for us to really have a discussion. I've been asked in the past to talk about a number of different topics, whether that is 988, whether it is the Behavioral Health Commission, other areas pertinent to mental health. I'm actually going to present a little differently to you this morning, but I'm going to start off with, I prefer interaction with who I'm speaking to. So we're actually going to start off with what I call audience participation, right? And then, excuse me, and then I'm going to present some data that looks at mental health pre-2020, during 2020, and then what we've seen after 2020. So I'm not speaking specifically using the word pandemic, but we're going to focus on the year 2020. And then I'm going to look at and show you some outcome data that we have from a survey that we do that may or may not surprise you, the results of. And then we'll go with questions. So, what's in a number? I have to move up so I can actually see the slides. So I'm going to show you a number, and I want you to tell me what that number represents. So 12.9 million. It's the estimated population for Pennsylvania in 2023. It's a good group. 1885. 1,885, because saying 1885 is misleading. You might think that's a year. Who said that? You also had the population right. He's not a ringer. I didn't put him there. This this is data from the CDC, which they get from us, but this represents the number of suicides in Pennsylvania in 2021. $5,168. I'm sorry? This is death by overdose. This is the number of individuals who in 2021 died by drug-related overdose. One in five. So 1 in 5 represents, for adults in the United States, the number of individuals who carry a mental health concern. It also represents 1 in 5 individuals who suffer from addiction. It also represents more than 1 in 5 of youth that have a mental health challenge. So 1 in 5 means several different things. One in 25. Now, if any of you get this.
And for answers just for accessibility.
That's a good answer, but it's not the answer. Yes.
Serious mental illness, Doc. 1 in
Yes.
25.
It represents the number of individuals in the United States who carry a diagnosis of serious mental illness. And for those who may not know, serious mental illness are things like schizophrenia, major depression, bipolar disorder. This is a really, really smart group. All right, so those are the numbers that I had for you. Now I'm going to go into looking at some of the data. And this is data that represents, it comes from the behavioral health managed care organizations, the people served within, by them. And we look at a 5-year period. So I'm looking at from 2017 up through 2022. Not all of 2022 data is in yet because of data lag, but most of the year is there. I think there are 10 months worth of 2022. But it helps us to be able to look at some trends that we've seen. Excuse me. The red line represents mental health services. The yellow line represents SUD services. And so this looks at individuals that were served. And this is all based on encounter data. Encounter data is not a perfect data set. And there are some limitations in the data, but it does, as I said, help us see some things. So what we see from this slide in mental health is that from 2017 to 2020, there was an increase in people being served, right? Well, at least in 2019. In 2020, we saw a dip in mental health services. And then 2021, we saw those numbers go back up. And you see that for substance use disorder, there's some slight variation, but that number doesn't change that much. So on this one, this is the units, and you will see that there's kind of this sawtooth pattern where units went up, but there was a sharp decrease from 2019 2020. So 2020, the number of units being provided actually went drastically down. They have come back up again for mental health and for substance use. You see that it really doesn't change all that much. And there are a couple different ways that I end up looking at this this data. There's actually a table that prints out the numbers. Now, on this slide, sorry, my blood sugar's up a little this morning, and so, all right, so this is the average of units provided, and you'll see they flip on this one. SUD is on top, and the number of units provided for individuals with SUD actually has a sharp increase since 2020. There was a dip in SUD and a dip in the a dip here in mental health, but that has also come back up. But it's clearly not as steep a rise as the units within SUD. This is the table that really kind of has the numbers with it, and I believe I'll be able to make this deck available to you when we're done. So another graphic presentation of what I talked about, and we're going to look at a number of different factors in this. So look at individual levels. We also have a breakout for age, race, and gender. So again, you will see that, whoops, sorry about that. That slight dip here, but then the increase on mental health services. And then for SUD, there actually was a slight increase in 2020, but this big increase here in post-2020. I don't want to block people that way. I should have brought my own laptop. So on this slide, you have, sorry, give me 1 second. So this is age, and this first one is age 12 to 18, then 19 to 34, 35 to 64, and then the 65 and up. And you see the patterns here are pretty much the same, where there was this increase post 2020. There should be, this is relatively the same for the youth, but then the increase. And we know that youth have been very much affected by the pandemic. And we spend a lot of time talking about the crisis, mental health crisis with youth. And this data kind of reflects their receiving treatment, although, and I don't have it in this data set, where when kids were not in, a lot of mental health services are provided in schools, when kids were out of school, that was a very big issue. And then we've all know about the workforce challenges and how at all levels of providers have been affected by not having enough staff to provide the necessary services. And we see that also with psychiatry. I haven't actually treated patients. Probably the last time I think was 2014 when I worked in a clinic. But there are individuals now who are seeking mental health services, and they will do a Google search for psychiatrists. My name comes up, so I get calls at my office for people who are frantically trying to find a psychiatrist to take care of them. And we can have ongoing discussions about how best to address that, but it certainly is something that we've been seeing quite a bit. Busy slide, but again, you see the same types of patterns where post-2020, there is an increase in individuals, there's an increase in units of service, and except for wrong button, sorry. Over here for SUD, you see that it went down actually here. So, one of the things that really helped during this was our use of telehealth services. It really, I think, was a timely and a godsend for individuals in need of services. There are some limitations to telehealth, though. I will tell you one of my concerns with telehealth, and have long been an advocate well before the pandemic, but one of my concerns is the fact that there's an increasing number of, I'll speak towards psychiatrists in general, and I don't know if there are any psychiatrists in the room or not, but my concern is that more and more psychiatrists are only interested in providing services via telepsych. To me, that's problematic because not everyone wants telepsych, right? Some people want to be seen by the individual who's treating them. And if we all are only seeing people through this one mechanism, then what happens to the other individuals? So, and one of the premises that our public mental health system is built on is choice. And if we take away someone's ability to come in and see someone, we remove that portion of the choice. So, again, I'm a big proponent of telepsych. I think it has done wonders for a number of people who would not have received treatment in any other way, but I personally do not believe we can put all of our eggs in that one basket. All right. These slides, I'm not going to speak to all these slides, but again, gender shows you the same sort of pattern. So all these patterns are very similar. I'm going to go ahead towards where it talks about the top 5 for each one. All right. So, excuse me. On this slide, we have the top 5 mental health services and the top 5 SUD services that were provided during during 2020 and then after 2020. And I don't know that there's any big surprises here. I mean, outpatient is clearly the most commonly used. I'm happy to note that peer services is high on this list and moves up. As we have looked at services being provided and the ability to help people in their recovery, obviously with the workforce challenges, peers play an even larger role in being able to help us meet individuals' needs. And this data reflects that there's still lots of work that we need to do to grow our peers, and that's something that we're working on. But I think this data is really good in showing us what is used. So, all right. I want to spend a little bit of time talking about individual satisfaction in what they receive. So this comes from the MISSIP survey that we send out. We send out roughly 7,500 surveys to individuals who are served in the via public mental health, and they are randomly sent out. And the results end up going to SAMHSA, and then we are compared to every other state. And I don't know if there's somebody from Mental Health America in the audience, but when Mental Health America puts out their ratings of states, this is some of the stuff that they look at. So this data shows that, and this compares 59, so it's the 50 states plus territories, and penetration per 1,000 individuals that are served. The community utilization is looking at all services that are not inpatient. So that's why it says community. So in the United States, there were roughly 8 million people that responded to the surveys. And the Pennsylvania's rate on this was 44%, which you see is almost double of what the United States rate was. So it's something that when people see that, they say that Pennsylvania is doing a really good job in this respect. And again, this 44.09 just reflects outpatient services, does not include inpatient. All right. A really important question for people is, what are they receiving, and how satisfied are they with the services that they receive? When we compare what the responses are for adults, in Pennsylvania, 82% had a positive response. versus the national average is 72. So again, Pennsylvania, at least on the surface, appears to be doing a good job if we look at satisfaction of individuals actually receiving the services. Not all the states responded to this. There were 47 states and territories that responded, that provided data for this portion. When we look at youth, the numbers go down. When they send out the youth surveys, in some cases, it's actually the youth who's responding. In other cases, it's family or caregivers who are responding. But 79% said that their responses, what they received, they were positive about. The 72% is consistent. I thought there was another slide that I had. But anyway, what this shows, though, that for services provided, we saw a decrease in individuals being served, units provided during 2020. 2020 was a difficult year for everyone. And we've seen a rebound since 2020. The limiting factor will be the workforce challenges and the number of people that are available to actually provide the services. I think that overall, though, that in PA, one of the things that we can at least have be happy with is the fact that overall, most people receiving services are happy, or at least view the services as positive. I won't necessarily go as far as to say that they're happy about the services that they're receiving. When we talk about mental health services in PA, oftentimes people will use the term that our system is broken. I will tell you that I do not subscribe actually to that term. What I talk about is the fact that our system has many challenges, and really it's up to us to rise up to those challenges. And I think one of the things that you will hear throughout the rest of the day is how the proposed budget goes about helping us to tackle some of those challenges. So with that, I am happy to take any questions you have.
Thank you, Doctor. Thank you. Okay, and just a reminder, if you raise your hand, my staff will give you a card, and we will try to do that. So just raise your hand, and that's how we'll pass them up as well. So the staff will go through. Doctor, you mentioned several things in your presentation that caught my eye or ear as well. And one in relation to telehealth, which we have struggled with the legislature. Last session, some of our friends got caught up on the abortion discussion, and it kind of ended up limiting some things that we were looking to do with the legislature. But in relation to telehealth, you talked about providers who are becoming telehealth only. I hear about this as a challenge, especially for youth, especially for those who are new to therapy and those who are trying to figure out how best to connect. And I wonder if you can give some thoughts as to how telehealth has been most successful in relation to adolescents.
So I think that, I should preface this that I'm not a child and adolescent psychiatrist. I'm a general psychiatrist who has special training in geriatrics. That said, there are, youth today, more so than in my day, and probably also in many of the days of the folks in the room, are more tech savvy than we were. And some of them prefer communicating either via text or on video. But the truth of the matter is that that is not the best treatment modality for a lot of individuals. There are individuals who it absolutely is the best way to reach them. Before the pandemic, we actually had conversations with an OMSAS about individuals who suffer from agoraphobia or fear of going out, right? And who were not able to be treated because they would not come into the office. And if you were in an urban area, that really was the only mechanism or the primary mechanism available to you. Telehealth has allowed us to reach those individuals, and providers will tell you that their no-show rates have significantly dropped. But again, from my standpoint, it doesn't work for everybody.
How are you measuring the success, though? I mean, I understand that you may have a drop in no-shows. What about just the success rate? I know you mentioned satisfaction. What about just the difference in sort of quality measurement? Is there a quality measurement in a way that can tell that telehealth, while definitely helping in maybe a therapeutic desert as far as getting access, but is that therapeutic model as successful as in-person model?
So most of the data is actually based on satisfaction surveys. Mental health has been a slow in uptake as far as measurement data, although we are moving more and more into measurements, and that will be able to provide the answers, because then you can use those measurements and how something was delivered to look at how effective it was.
Do we know enough to be able to say for certain that telehealth therapy is as effective as in-person therapy?
That's an interesting question. I don't know that I can give you a concrete answer to that. Again, I think that telehealth has provided a lot of benefits, but it's not a panacea.
Thank you. You mentioned workforce shortage, and by the way, I'm going to do my best on a couple of these as we go. But you mentioned workforce shortage. I continue, and I'm glad to see the satisfaction rates of the survey information that you have. That's tremendous. One of the problems that I keep coming across is that nobody knows, or seems to know, how many people are actually seeking care, in need of care. There is no waiting list of sorts that tabulates with certainty the number of people who are in need. For example, in certain disability fields, we can tell you how many people are on a waiting list for services. We can do that. On the mental health side, from what I'm told, there is nothing that tabulates that in relation to measuring the need. Am I wrong, or how are we tabulating the need?
I don't have good numbers on, and we really talk about wait times, and I don't have good numbers available to me to allow me to currently answer that question for you in a cognizant way.
Would you agree that that understanding the need in Pennsylvania is something that we should be spending time on?
Oh, certainly, we want to know what needs individuals have, and because then we can figure out how best to meet those needs.
The workforce issues that come up, and I've heard a variety of proposals in the legislature to talk about this as well. I've heard things about trying to encourage people coming in, as far as incentivizing things through financial assistance in school, trying to make it so the governor, for example, has a tax credit plan for nurses, teachers, and so forth. So we've heard a variety of things about how to target a buildup in professionals. What would you do? What would be your suggestion in how we can best build up the workforce here in Pennsylvania?
So and there are many things that have been talked about. I think there are a number of different strategies. I think, obviously, you know, the things that are most talked about are whether it's loan forgiveness, you know, those sort of making salaries competitive, those sort of things. But I think one of the things that oftentimes gets lost is the fact that we need to build pipelines of individuals for the human services field. I believe that starts by having conversations with individuals when they are in 8th, 9th grade, and showing them individuals who do this work. I go back to my interest in medicine, and I was involved with a group when I was in the 8th grade that actually gave me the opportunity to meet with people in grades higher than me, but also in college who were interested in medicine, and then people in medical school. So it helped prepare me along the way. I think more efforts in that will help us, because whatever we do now, we have to be looking ahead in how we continue to fill those spots.
Thank you. I will be honest, I hear more about cost problems and student loan issues, not in the PhD level, but below that is what I come across, because often rates and so forth are not making it so that some of our licensed professionals below the PhD level seem to be able to afford to do the work and pay their student loans. Speaking of what, look, we in relation, we all know that here in Allegheny County, the largest mental health provider, a daily provider, is the Allegheny County Jail. One way or another, we have individuals in state institutions of a variety who are hopefully at some point transitioning out of those facilities. In relation to community services on ways to support individuals as they're coming out of a variety of state institutions, what would you like to see the state do?
So I think, number one, if we want to decrease the number of individuals within jail settings, jail or prison settings that have mental health concerns, then we need to look at preventing them from preventing the arrest, right? One area with that is the crisis continuum, so that we have individuals, if they are in a behavioral health crisis, they are responded to by behavioral health professionals and not law enforcement. Oftentimes, law enforcement will arrive on scene and they may not see another choice but to arrest a person. The crisis continuum provides that choice and helps get the person the care that they need.
In relation to trying to get access to care, we still have an issue. Some states have moved forward with having mental health registry for beds, so that if you are having an episode where you need more inpatient assistance, you may go to an emergency room and then try to find an inpatient facility. We've seen states that have created a statewide database for mental health beds, so no matter where you are, you'll be able to program in the type of bed and need that you have and see where the matches is for your for the facilities that have an open spot. Do you have opinion on mental health bed registries, or do you believe our system that we have is currently adequate?
Trying to figure out how best to respond to that question. So registries, there are pros and cons to registries. Some states who have enacted registries, it is largely voluntary. And then you have, whether it's a hospital or whether some other provider who has beds, they don't always then fill that in because it can create issues for them in having dedicated staff to keep the numbers accurate. So again, there are pros and cons with that. Will I say that our system is adequate? I would say that it is challenged, again, because obviously if someone has a need and they are sitting, for example, in the emergency department, I do not think that that is appropriate. Again, I will go back to, though, that if we work and develop a functional and adequate crisis continuum, it will address a lot of those issues.
And Doctor, I appreciate your word choice on a couple things there, but just so I know, look, you can have a system that is fantastic, but still has its challenges, right? Is Pennsylvania's mental health system adequate to our needs?
So I think another way to ask that question is, are all Pennsylvanians' mental health needs met? The obvious answer there is no. Everyone's mental health needs are not met. So there are a number of things that we can do that will help us help those individuals. And the counties will tell you that that they know the providers, they know the people served within their communities, they know their needs, but that they believe they are insufficiently funded to help meet those needs. So
Are they insufficiently funded?
Well, they have had they had a decrease in mental health monies in 2012, right. And the needs have not gone down. So I would say the answer is yes. Okay,
thank you, Doctor. In relation, we talked about some build out, obviously of staff, a workforce. One of the things as well, we have a question in relation to black therapists, as referenced here in the question. But how about a workforce that kind of reflects the entirety of our of Pennsylvanians' experiences? My belief is that we are struggling in relation to our workforce to reflect that diversity, no matter how you divide it up. How best can we be working to change that and have that sort of greater support system in place? What could we be doing for that?
So I think number one, it starts with an assessment of what the community actually looks like, right? And then it requires some work in letting people know that there are opportunities, right? Because people want to work. They're looking for opportunities, particularly students. But if they do not know what is available and how to go about achieving those things, then those are not likely to be areas that they will go into. And I'll give you a prime example is when I entered medical school, my goal was not to be a psychiatrist. And some people in the audience who know me may have heard this story. There were a lot of influences that drove me to being a psychiatrist, but one was during my psychiatric rotation, there was a young African-American youth who really was somewhere like 4 to 6 years younger than me. So it was really in my age group. And he kind of gravitated to me because I was really the only person who looked like him. And that had a profound impact on me and led me to going into psychiatry. So part of it is exposure. Again, I talked about reaching kids when they're 8th, 9th grade, and letting them know what is available.
Yes, and in relation to your experience, I'll say the black experience in relation to mental health, but also the LGBTQ experience here with it, how best can we target resources into communities now? Like what, I'm concerned, for example, I talked to a friend of mine in relation to a question that came up in a different community I'm concerned about how best either the system can adapt or the state can make that change as quickly as possible to bring resources that people can reflect themselves in to schools, to the place in particular where young people are, college campuses. Is there an idea that we can go, okay, this is what we should be doing to get somebody in there now?
Well, I think part of it starts with listening to, listening to individuals, right? So I think, groups such as the Trevor Project for the LGBTQ community, so that we hear and are making informed decisions. But I think that's really where we start, is being able to listen to people.
And everyone, I'm going to do my best. Everything that we don't get to, we will then submit to the good doctor, and then we will post on our website, I think, the answers to the questions, so that way you can, if we don't get to yours, you'll see it as best as we can. Doctor, eating disorders, mental health issues, is it eating disorder a mental health diagnosis, and or what is the correlation between the two?
So eating disorders are within the diagnostic manual, DSM-5. So yes, they are classified as mental health disorders, but it's more complicated to that, because there are physical health concerns that come with eating disorders.
So, and I apologize. Bulimia, is that a mental health diagnosis?
Bulimia is listed in the DSM-5, yes, sir.
Okay, all right. We have a couple questions here that get a little complicated for me, just in relation to, I guess I'll say, funding of services, and in particular, Medicaid renewal. For example, I'm going to do my best on a question, see where you might be able to lead us for it. But how is the state reconciling participants on Medicaid, especially those on community health choices, who are failing to submit a complete Medicaid renewal? And my belief is that there ends up being, if there's a problem or if there is a delay, could be they take 90 days for a reconsideration period. What can you help us out with in understanding challenges with making sure those who are in need of those types of services are not losing them in paperwork or delay?
Yeah, that's not my field of expertise. That's not a psychiatric question. That's more a...
Well, you got to pay for it. I mean, right, one way or the other, we got to pay for your services.
Right. So the department has been sending out notices, getting people to reapply, right? So, the message has been that people that have been receiving Medicaid are not just being dropped off the rolls, but that they are, their normal application time, their renewal time, they should be submitting applications for renewal. And that message is being delivered not only via the department, but also by, I think I heard Community Health Choices as part of that question. So their managed care companies are also providing information to their membership, as well as the behavioral health and the physical health companies.
I will tell you, Doctor, I hope you can take this back with it. The renewal process is often too complicated, and you make one mistake, and you could be in a big problem, and then you have months and months of cleanup work that needs to be done. So, if you can, of course, bring that back. We would appreciate that. I'm going to do a couple quick things if I can, Doctor, so please help me out with it. Is there programs at all to help? How would we get seniors to be more comfortable with telehealth? Is there some effort, thought as to how to make that more accessible for seniors?
So telehealth is being provided to seniors. there are ways that we could work with AAA, their Agency on Aging, that are working with their agencies as well as with senior citizen centers. The thing about telehealth has to be provided in an area that is able to provide confidentiality and privacy. So
Right.
there's a number of different places where it could be delivered for seniors.
Doctor, concerns or thoughts regarding the deaf or deaf-blind community in relation to mental health? How are we making sure therapist options are available for that community, deaf and deaf-blind?
So OMSAUS actually has an individual who that is her area. I will be honest, I have not heard of any issues. That does not mean that there are none. And certainly if someone is experiencing some issues or concerns there, I'd love to hear about it so that we can intervene.
Doctor, how would you classify the therapeutic needs of foster kids? How are they being met appropriately in our system?
This is I did not expect all of the questions that I'm getting here. So I will tell you, so we have done a big look at foster kids, primarily related to medication management in foster kids. We started this work back in, I want to say 2015. I might have my years because sometimes things kind of run together for me. But we actually put out guidelines and actually have seen a dramatic decrease in the number of psychotropic medications that are provided to foster kids. We're now we've expanded that and are looking beyond foster kids and trying to take a look at all kids. And that work is underway currently.
Doctor, trans kids and people, suicide rate is astronomically high. What's one thing we should be working on right now to help with that?
So I think the biggest thing is letting groups know that there is hope, right, and that they're not alone. The suicide rate actually went down in 2019. It has gone up. The two biggest groups that have been affected are trans and LGBTQ and people of color, youth of color. And so I'm not sure where
this was not fair. I should have given them a lot. But Doctor, I'd love to hear. Can we talk about that as well? Can we come back on that, you and I?
Absolutely.
All right, Doctor, I appreciate it. Let's hear it for Dr. Adair.